The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. This is Mike Sappington from Triarc. I'm the chairman and managing director. We wanted to get out with you today to share with you a little bit more about where Triarc is, where the market is, where we think that we want to help you succeed in this move to value. And so today's webinar will include myself, and then Julie Lundberg as well will be speaking specifically regarding the MIPS and the macro program. But before that, I wanted to take you on a little journey to really talk to you more about where we've been. I don't think we've done a good job over the last couple of years of talking to you about Triarc and Triarc Health and where that's going and how that's impacting you positively. And so I wanted to spend a few minutes before we get into the macro MIPS story to really give you some history and some background about who we are and where we're going and why we're still a good partner for you today. So thank you very much for joining. Happy New Year for all of us, and let's get going. The first thing that we've been doing over the last few years is spending a lot of time about thinking about value-based care. And there's a lot of definitions to it, so I really wanted to level set everybody and get a clear understanding of where we are with it. First, it's very basic. Value-based care is the intersection of cost and quality. We all know, and the whole industry knows, that we're just not getting as much as we should out of our healthcare dollars across the board. And so there's always a tremendous amount of pressure to improve the quality and reduce the cost. And so a lot of the payers have been coming out with programs to specifically deal with this, and in particular, Medicare has led the charge, but there are also many other programs out there. So the purpose of value-based initiatives really is to shift the care delivery from a pure fee-for-service, volume-driven model to more of a value-driven model, and really to closely align the incentives from the payer through the providers all the way through to the patient. In this particular model, I think that the difference is physicians have to worry about the total cost of care. That's not really had been done historically. We live in a very fragmented healthcare ecosystem, and we are shifting that and moving very rapidly towards more of a total cost of care ecosystem. And so really that's the biggest story. What's also happening is something called population health and trying to manage population and subpopulation. So what does that really mean? It really means segmenting particular populations, grouping them, benchmarking them, and analyzing them by disease condition, and then running programs against those disease conditions to try to improve the health of those populations or subpopulations. So that's a brief overview of value-based care. We're going to talk a little bit more about it as we move through the presentation today. What we've done is, yes?
This is Sabrina. The slides are not moving. Are you moving the slides?
Let me try.
Sorry, everyone. Stand by. Okay. Now we see a different slide. Thank you.
Okay, sorry about that. And so talking a little bit more about, let's talk a little bit more about what we were doing. So a couple of years ago, 2013 and 2014, the industry was in the throes of the meaningful use story, and we started to think about what's next. And from our point of view, what was next is it was clearly moving down. Once there was a platform in place and technology in place, the next step of that was to what do you do with all the data? What do you do with all the information? And so we started to really think about that very carefully. We really looked around, and we found the Institute for Healthcare Improvement. The Institute for Healthcare Improvement has really pioneered the concept called the triple aim. And the triple aim is really these three particular categories. It's about improving the patient experience and both the quality and the satisfaction, reducing the per capita cost of healthcare across the board, and then improving the health of populations as we just spoke about. And so what we started to think about is, well, how do we play a role in that? And we really wanted to get in front of that initiative, in front of those programs. And what do you need to do in order to do that? Well, you need to have a value-based partner. You also need to really think about your care models and how you're transitioning those care models, how you're going to communicate more effectively and collaborate with people across the healthcare ecosystem, and then what organizational structures are really required and what competencies were needed to be able to move into the value-based care world. And so as a result of that, we really took a step back and said, you know, that's way beyond just a technology company, and that's what GlowStream really started off being. And so we decided to make a shift to the value-based world. And that's when the brand TriArc came along. And so TriArc is really, it's an acronym that stands for Achieving the Triple Aim by Aligning and Redesigning Care Around Quality. And that's how we got there. So back in 2014 and 2015, we really decided to jump ahead and put a lot of energy and a lot of focus on value-based care, rebrand the company, and align with that top to bottom. So with that, we moved on, and that's what we did in 2014. I know that many of you did not appreciate that or really understand it at the time, but I think it'll become increasingly clear as we move, you know, through time how important this really is. And so when we talk about aligning and redesigning care around quality, these are the elements, these are the functional requirements that are needed over time. You have to have performance management. And performance management is someone who truly understands, you know, the programs, understands what's trying to be done, understands what's fundamentally driving the programs, and then can align people to those programs and the success of those. And we believe that performance management is a key differentiator in what we do and how we go to market today versus just a technology company. You know, you also have to have community-wide collaboration, population health management tools, tailored health and wellness programs, and then all of those are being today aligned by the payers and others, you know, to make sure that really from the patient all the way through the whole ecosystem that everyone's incentives are aligned. Of course, you need tools and technologies, and we're continuously investing in that. We spent a lot of money and continue to spend a lot of money on R&D, and we will continue to do that moving forward. And then on the left-hand side, you have care management. It's interesting. I think if you just flip those words and said managed care is really driven by a payer. Care management is driven by a provider. And that's a significant difference. And so we need to give you the tools to better manage the care of the patient, again, by disease condition or by population. And then the next step is we have to continuously engage the patient in their own health care, either through programs, through reminders, through mobile phones, et cetera, et cetera. And so we continue to think about how to do that. These initiatives that you see on the screen here are what's driving our strategy. We really believe in this. We believe that if we can improve the quality of care and help you deliver that in a meaningful way, that you will be better off, the patients will be better off, the population will be better off. So certainly costs will be driven down, and you'll be very successful in this market. And that's obviously our goal. The challenge with this is that every payer has their own initiatives, and there's a lot of acronyms, and there's a lot of programs out there, pay for performance, BCMH, ACO, shared savings, episodic bundle payments, capitated arrangements, and then all these new terms that people are referencing today, performance management, care management, population health management. And so it's very difficult for independent practices to get their arms wrapped around the complexity here. And so what we've decided to do is really think about how do we help you do that? How do we structure our business? Because we can't do it the way that we were doing 5 years ago and be successful. We know that, and so we've really thought about, hey, these programs are coming. What do we do with it? Over the past couple of years, where I've been spending most of my time is really talking to the payers, and we've done a good job there. But one of the things that we recognize when we start talking to them at the executive level is that there's a giant gap between what they believe value-based care and population health management, care management is, and practice's ability to execute against that, against those programs. And so as a result of that, we really started talking to the payers about how do we help you be successful, because we got to create an alignment between the payers, the providers and the patients. And so what TRIARC is doing is really trying to get in at the payer level and help them, create programs, value-based programs across the board that are easily received and can be actually delivered and done something about. And so we've done this historically, and we all started off in this journey, many years ago, doing this with Medicare. Medicare came out with meaningful use and the quality, the PQRS programs, and many of the other programs. And we would take those programs, distill them, understand them, write technology, create training and support programs for all of you, and then we'd roll those programs out. And what we've started to do is say we really need to do this across the board for all payers, and that's what we've spent quite a bit of time, and I've spent quite a bit of my time in the last couple of years doing. So we really made a transformation. The company's made a transformation, and I want to talk to you a little bit about where our focus is and how that's a benefit. And certainly we've got a strong team, a strong leadership team that's been very consistent over the years. We have a steady and growing business, so the business is profitable. We've instituted a performance management layer into our offers, and we're excited about that. We are extremely focused on value-based care across the board. Obviously, we know what we're doing. We have deep industry knowledge. We're talking to everybody throughout the ecosystem. And the other thing that I think we also have a lot of thought leadership, and we have the ability to act very decisively. If we decide to do something, we can do it very quickly. I think that we've proven that we've been able to do that. Certainly, we continue to invest across the board in our cloud platform. We have many developers every day pounding away at all the different modules and things that we're doing. We're spending a tremendous amount of time, energy, and effort doing just that. We own our own development center, and that enables us to rapidly move technology forward. We have about 5,000 users. We're in 32 states. We did some analysis. We do millions of transactions, and so it's unbelievable how many faxes get sent and how many e-prescriptions get sent and lab requests, et cetera, through the network. We processed over $1 billion worth of charges last year through the network, and so we're a meaningful component of the healthcare ecosystem. The products and services that we deliver, they do work, and people are using them every day. And so we're very proud of that fact, and we're excited about continuing to help you all move forward in the future. The history is here on the screen, but I think the most significant thing is, why did we go from TRIARC or Glowstream to TRIARC? Hopefully I shared a little bit about that earlier. One of the things that we did late last year is really formed a new group, which is a new part of the TRIARC family called TRIARC Transformations. Piyush Khanna is going to lead that. That's really where we're engaging the payers and helping them, craft programs and understand their programs and can roll those programs down to the provider level. And so we're getting a lot of traction with that and communicating and talking with a lot of payers as well. Transformations is very simple. The purpose of transformations is to help move from fee-for-service to value-based care. And we've talked about it from a very siloed, fragmented care environment to a one-team care environment. And these are the buckets. You need care management. And the question about care management is, how do we redesign care around quality? How do we collaborate? How do we manage the care continuum? Obviously, we need enabling technologies beyond the point of care tools that we have today. We need a more holistic view of things. So what information needs to be available when and where? How is it best gathered and delivered? The one thing I do want to just introduce today is this idea. We want to gather a lot more data. The purpose of this is really to share it back with you, to provide you the tools. We think that our users are some of the best providers in the industry, and so we want to brag about you. We want to give you the tools, the ammunition, the information necessary to present to payers and others that allow you to be in a very competitive and strong position moving forward. And so that's an important initiative for us over and throughout the year. And then, of course, we need patient engagement, and we're always asking these questions. What's the best combination of services for a particular person, and then what's the best modality to give them information or deliver care, et cetera, et cetera. And then population health we've covered already. So transformations is really kind of looking at all of these buckets and saying, how do we prioritize asking these questions, and then what tools and services can we deliver to help make this move forward, seamlessly. Sorry. So in summary, Triarch Health was built to deliver value. It was purpose-built, was thought about, and we've been, Glowstream is a 10-year-old business, and Triarch Health is now a continuation of that, an evolution of that. And the purpose of Triarch Health is to achieve the triple aim by aligning and redesigning care around quality. And the offers that we have to help you simplify and ease your shift to value-based care is the Transformations Group. We also have what we call the Value-Based Group, and the Value-Based Group is to help organizations like ACOs or shared savings or bundled payment alliances or capitated groups to really think about how to deliver value across those ecosystems and across those populations, and what structures are appropriate, what legal entities are appropriate, how do you structure those, how do you manage them, how do you do things like that. And so that's what Value is doing. And then on the Pro and Complete side, we made a big decision last year, and we think it's a significant decision for the company and for you. We recognized that we were coming to you and asking you to pony up more money every time there was a regulation change or every time that there was something else that was needed or required. And we heard your feedback. We understand that you don't want to be nickel and dime. And so we made a strategic decision to really simplify our offers. And the purpose of this simplification is that it's all inclusive. Pro and Complete. Pro is the product service side, but it also includes performance management. It includes the technologies and services, patient engagement, and then the analytics and optimization. And so Complete is where we do it on a percentage basis, and we also do the RCM side. The Pro is where we do it on a technology basis, service basis, and both of these service offers also include performance management. And so we really heard you. We understand the concern. It is increasingly costly to operate an independent business in this regulatory environment. And so we're trying to do our best to simplify the way we do business with you. And so there's no more training, there's no more separate training, et cetera, if you're in one of these programs. It's all inclusive. And there are a couple things on a variable basis where vaccine, for example, it's hard for us to include that because it's so variable. But all of the technologies, all of the tools, all of the services are included in these offers. So we're excited about those. Let's move on to the payer space real quick. I like to think about populations of people. So when you think about your practice, you really think about, what are your top 5 payers, what are your top 6 payers, or even your top 10 payers. When we talk to practices, most of the time it really boils down to 2 or 3 of their top payers represent 70–80% of their business. Well, each one of these payers has a value-based initiative. We of course know that Medicare's got, they've got the macro program, but also, when you think about Blue Cross, which or Anthem or whatever is in your state, whatever Blue Cross affiliate is in your state, they have a strong desire to move to value-based care, and so, and then those payers also have different programs that fit into these buckets, right? So Blue Cross will have a Medicare Advantage program. They'll also have an offer on the exchange, and they'll also have a Medicaid, managed Medicaid program. And so you really have to understand what program you're in and what they're trying to get you to do. I will say with Medicare in particular, and we saw it firsthand when people got frustrated with meaningful use and gave up on it and didn't feel like it was something that was important. I want you to know that all of these payers want to go on a value-based journey. And they are fundamentally building the blocks to take you down that path. And if Medicare is a big payer, or Blue Cross is a big payer, or you're in one of these other sub-markets, you really truly need to understand what those payers are trying to do and where they're trying to take you. And it is my strong advice to get involved in those programs as soon as possible. We're going to talk a little bit more about it here in a minute, but essentially, there's a lot of transparency coming. There's a lot of there's a lot of scorecard, a lot of benchmarking coming that's going to be publicly available. And so it's not just about delivering care anymore. It's about collaboration. It's about adopting these programs. It's about getting on board. It's about the transparency. It's about the cost of care. And so I know it's complicated, and I know that it's hard to change tires when you're doing 85, 90 miles an hour down the road. But this is exactly what has got to happen. And even with the new administration, I certainly don't believe that value-based care is going to change. Obviously there will be things that will be changing, but I think value-based care is here to stay. Everybody wants better quality, lower cost. There's no one on the planet that doesn't want that. And so, if that is here to stay, what form it's going to take, we'll have to decide, or that will have to be decided. But in general, this is currently CMS's strategy and timeline. They really want to move down the value-based care program and down the value-based care line. They also were able to convince people to implement the MACRA. I think it's really important to understand that the MACRA, which is MIPS, which is the law that really that is the foundation for MIPS, is not the ACA. It is not that part. It is not that law. It's a law that replaced the Sustainable Growth Rate, which was an annual law that needed to be passed, or an amendment that needed to be passed to the SGR to deal with inflation, which was never done. So a couple years ago, on a bipartisan, passed with overwhelming bipartisan support, it changed the way that healthcare providers, doctors in particular, are paid. And that's, again, not part of the ACA. So if the ACA is repealed, that is not the MACRA. The MACRA is moving forward no matter what, unless there's some significant change in the law. And I just don't think that that's going to happen in the short term. And so, we're on this journey, and we're going down this path, regardless at this point. So let's talk. We've talked about every payer's got a program. Certainly, the MACRA MIPS program is a big one. I do want to emphasize that it started. Everyone, it's on, right? It started January 1. I think there's some apathy in the marketplace with all the programs that have been thrown at you. I think that there's a lot of confusion in the marketplace about what's happening in the election and all that other kind of stuff. But I do want to emphasize, and part of the primary reason for this call is this urge people to and tell people that, hey, the program started. We're live. It's in place today. And it's a massive move to value-based care and away from fee-for-service. It's the largest incentive penalties, ever passed in the law for healthcare. Everyone's going to be impacted. It's not a voluntary program. You're in it no matter what. It runs for 10 years. If you thought meaningful use was complex, wait till you hear Julie talk and you hear about all the things that are going on with that. And then I think that, and I applaud Julie. Julie's been very active with Medicare. On phone calls with them and on webinars with them and responding, and she's become one of the nation's experts on this program. And so, they're listening to us, and she's got stories, and she's found gaps in their thinking, and was able to get some things clarified. And so, we're on top of this program. We understand what it is and where it's going, and how we can help you. And there's no opt-out here. And then the other thing is, it's just important to understand that you're going to start seeing public quality ratings. You're going to start seeing physician compare websites, et cetera, et cetera. And the other thing is that this is a continual management and improvement program, because you're always being benchmarked against your peers, and everyone's always improving. And so the net result of this is that it's not a static benchmark. It's a moving target for everybody, and you're all compared against each other. And so it does require somebody to be thinking about this continuously and pushing the bar forward and moving forward. So with that, I'm gonna introduce Julie. Julie's been really wonderful for us as the VP of Offer Manager. Julie takes all the industry information, customer feedback, regulatory feedback, technology feedback, mixes that in a bowl and creates a product and service out of that. And so with that being said, thank you, Julie, for all your time and energy. It's important and valuable. And I will turn it over to you, and we can go from there.
Thanks, Mike. Let's move to the next slide. Hi, everybody. Thanks for joining us today. So what are MACRA, QPP, Advanced APM, and MIPS, right? We love to call this the alphabet soup. In healthcare, we are traditionally horrible about our acronyms, and it just gets worse when you throw the government in. So just briefly, let's take a look at this slide and move from left to right. So MACRA, Mike talked about MACRA. MACRA has nothing to do with the ACA. This is the Medicare Access and CHIP Reauthorization Act. This was the, heavily supported both sides of the aisle. So we now have MACRA. MACRA introduced the QPP, the Quality Payment Program. How do I participate in the Quality Payment Program? I have choices. One of those choices is an advanced APM. APM standing for Alternative Payment Model. So I can do CPC Plus. I can be in an MSSP Track 1 plus 2 or 3. Notice Track 1 is not here, and we'll talk about that in a second. Or I can be in a new generation ACO. Those are ways for me to satisfy the QPP by being in an advanced APM. If I'm not in one of those programs, then I'm automatically in MIPS, the Merit-Based Incentive Payment System. So that's what we're going to spend the next couple of minutes breaking down for you. So what does MIPS break down into? It is quality, the performance category called quality, which is formerly PQRS, ACI, advancing care information, that's formerly meaningful use, and then CPIA, which is a relatively new concept for folks, clinical practice improvement activities. We'll touch on that slightly. And you'll notice we've got our big POW cost. Cost is not on this list because in the year 2017 being a transition year, they removed cost. They are not going to measure us on the cost performance category in the year 2017, but it's coming back in 2018, and all of the performance categories will be reweighted accordingly. So right now we're not being scored on cost, but we'll talk about it a little bit because you really should not ignore it. So we can go to the next slide, Mike. All right, who participates? This is an interesting slide because there's been a lot of discussion about this, and I've had to go back to CMS a couple different times and escalate when the answer was wrong and in conflict with presentations that CMS has made. I said, y'all need to get on the same page because your help desk folks are not answering the question the way your presenters are. So program eligibility. The different categories of providers here, so physicians, physician assistants, nurse practitioners, clinical nurse specialists, CRNAs. If you are billing more than $30,000 in your charged allowables to Medicare, and that's Part B Medicare, and you provide care to more than 100 Medicare patients per year, you qualify. But super confusing, the way in which you qualify and participate depends upon the type of practitioner that you are. So, for example, if I'm a PA or an NP or a CNS or a CRNA, guess what? I really don't participate in the ACI performance category, right? That was the old MU. And for those of you who participated in MU, you know that these mid-level providers did not attest for meaningful use. So it is following along that path. So if you are in one of these buckets, you don't participate in the ACI performance category. So what are they going to do? They're going to throw that 25% into the quality performance category. You're still going to be judged on a 100-point scoring system for your MIPS composite score, but the ACI category will not contribute to that. However, if you do send them ACI data, they will count it. So it's a lot to take in. My best advice is for folks to, recall the way you've participated up until now in the incentive programs, right? The mid-levels had to attest for or had to report PQRS, but they did not. For MU, we're following along that line. All right, perfect transition, Mike. Yeah, you can go on to the pick your pace slide. So this was a really, really interesting concept, and I give Andy Slavitt, the acting director of the ONC, a lot of credit for this because I think he heard us screaming, saying, you know, some folks weren't ready. So the transition year, 2017 is the transition year. If you do not participate, you will see a 4% payment adjustment on your Medicare payments in the calendar year of 2019 based on your performance in the year 2017. Okay, so you're going to get dinged. If you don't participate, you're going to get dinged. Okay, you would have an option to do what they call test, submit something. And for the longest time, they didn't articulate to us what that something was, and they have since fleshed that out. So you can submit a minimum amount of data. That could be a single quality measure, a single improvement activity. You can just report the base of the ACI, the base score of the ACI, something. Okay, your next option is the partial year submission. So we're all used to this whole 90 days, right? I swear there have been very few years over the course of meaningful use where we actually participated for a full year, right? They would change the wheels as we were going 80 miles down the highway, and they'd say, yeah, you guys are going to crash, so we're going to let you do 90 days instead of a full year. So same kind of concept. You can participate for a partial year, so a 90-day reporting period, and you will avoid penalty, and you may earn a small positive payment adjustment. So you might get a little bump. The best way to participate is that full year. If you submit a full year of data, you may earn a moderate positive payment adjustment. Now, what's really interesting about this is when you really dive in to this and you talk to the folks at CMS, they want to make sure that yes, your best way to earn the largest payment adjustment is to submit data on all the performance categories for a full year. However, your positive adjustment is not tied to the amount of information or the length of time. So hold the phone. What the heck does that mean? Why would I participate for more than 90 days if that's not really going to impact my ability to earn the highest amount of incentive? And when you start looking at how you participate and you drill into, let's take the quality measures, and one of the measures I'm going to pick is I've done the HOOS or the COOS for my patients who have a total hip or a total knee replacement. And I need to gather that patient-reported outcome data 60 days prior to the surgery, and then either not sooner than 60 days after the surgery, but up until 180 days after the surgery. Okay, whoa, that is way more than 90 days. I am going to have a heck of a hard time fitting all that activity into a 90-day period. So my denominator is maybe going to go down, or worse yet, my denominator's up and I haven't incremented my numerator and my performance score is low. So that is why they tell you your best way, your best path to earning the highest amount of positive payment adjustment is to submit data for a longer period of time. And now, it's important to note here as well, it is not either 90 or 365. It can be somewhere in between. So that is also a new concept for us. We've never had that thought before. It was either always 90 or 365. And here is where I'm going to make my pitch to all of you end users out there. No GlowStream user has any business doing anything other than the 90 or the 365. I don't want to hear about any of you just doing this test business. You are all capable. The system works. The dashboards count your activity for you. Yes, there's some workflows you might need to learn, but I encourage all of you to participate as fully as possible. All right, so that's my little soapbox about our users. They can do this. All right, we can go to the next slide, Mike. It's a little slow to advance. There we go. Oh, okay, so this is a big deal. This is not just about your money, folks. So for the folks out there who think it's too hard, I don't want to invest the extra time, I'm just going to take the hit. I'm going to take the 4% ding. It is not just about your money, folks. It's about your reputation. This is pulled straight from the final rule. I'm just going to read this verbatim. Public reporting. We are finalizing a process for public reporting of MIPS information through the Physician Compare website with the intention of promoting fairness and transparency. We are finalizing public reporting of a MIPS eligible clinician's data for each program year. We will post on a public website in an easily understandable format information regarding the performance of a MIPS eligible clinician or groups under MIPS. Oh boy. So this is patient facing. This is public record. Patient can go in there and do a little search and see what kind of quality scores your providers have. So please let's make certain that they're understanding that this is not just about their money, it's also about their reputation. All right, next slide. All right, so here we've kind of touched on the different categories, the different performance categories. Let's talk about them in a little more depth here. So this is, yes, I'm a Medicare Part B provider. I am not in an advanced APM. I am participating in the MIPS. How does it work? So I'm going to earn a positive payment adjustment, and I'm not even tolerating folks who are not going to earn, we're all going to either be neutral or positive, and I'm going for positive for our folks. You're trying to show that you're providing good quality care. So how does this translate? And we've heard this a lot, right? And this slide spells it out for us. Quality replaces PQRS. The clinical practice improvement activities, kind of a new category, not totally new, and we come up with some strategies and help you folks understand what does this really mean and what are the requirements. ACI, that's the one that replaces MU. When you see that dashboard, you're going to go, oh, this is not so scary. I've seen these before. And then cost really replaces the value-based modifier. That was a program that was really, most folks, it was kind of this sort of nebulous, we didn't really understand VBM unless we got really diligent and we created our EIDM accounts and we went in and we ran our QR URs. It was highly tied to quality, I'm sorry, to PQRS, because you had to participate in PQRS in order to not suffer the value-based payment modifier adjustment. That is now the cost program, and as we mentioned earlier, we will not be measured on cost in 2018, but we really do want to be paying attention to it. And I'm going to dive into each of these categories in more detail. So you can move to the next slide, Mike. So quality. Quality is the biggest performance category. Notice they're weighting it this year at 60%. In the proposed rule, this was at 50% and cost was at 10. They threw those cost points into the quality category. So again, we keep beating this drum. This is what replaces PQRS. And they did us a couple favors here, right? If you've participated in PQRS in the past, you know that it was continually escalating. You know, for a while we needed to report on one measure to avoid penalty. Then it was 3, then it was 6. It's been 9 for the last couple of years. It's been a challenge for folks to, you know, find those 9 measures and implement the workflows to capture the documentation in your chart and also report those codes. And we were big fans of measures groups reporting because that was a little simpler, 20 patients. So they've reduced that. And the measures you're going to see, guys, they're very familiar. It's all the same quality measures we've been bouncing around for years. It's just they've relabeled it into the quality category. So we need to report up to 6 measures. They're kind of fussy about which ones you pick. They want to make sure you've got an outcome measure or another high priority measure. And we'll talk about how our dashboard is going to give you insight into that. There are group reporting options, but most of our folks are going to pick 6. And we are going to get bonus points if we report those through the EMR, which is super cool because we can do that. We'll get bonus points if we do extra. And one of the really tricky parts about the quality performance category is understanding how you are scored. So that numerator denominator percentage, right now we might pull that up and run our CQM dashboard in GlowStream, and we might see that, you know, gee, look at us, we're doing awesome. We're at, you know, 97% for our medication reconciliation measure. Well, guess what? When they publish the deciles, and that's a whole confusing topic, 97% might get you only in the 5th decile, and you're only going to get 5 points because. So think about that bell curve when you were a kid, right? You might have gotten a 95 on the test, but you know, Sally Joe got 100, and she's going to get the A, and you're going to get a B because there was nobody else who got it. So you get it. It's like a bell curve. So very tricky. Important, very important to know what those deciles are, and we've got that information for you. So you can move to the next one, Mike. We're going to talk about, I'm thinking, ACI. So this was what MU was, right? This is MU. It's actually, it's a watered down version of what MU was. So there's a couple different ways to skin this cat. What I like about the changes they made with ACI, and this will make more sense when I pull up a picture of our dashboard, but there's four measures that you see listed here. The security risk analysis, sorry, that did not go away, guys. You still have to do that. E-prescribing, providing patient access, right? That's your portal. Health information exchange. That's that summary of care. You have to do these things for one patient to achieve the base score of 50, and then you've got other measures, 9 more measures that, or I should say there are 9 total measures that contribute to the performance score in this category. And it's going to make more sense when we look at the dashboard, but essentially you have lots of extra credit opportunity in this category now to get to that 100 points. There's actually 90 points available for you, and you need only 90 of those. So what it lets you do is pick what's a good fit for you. If it's not a good fit for you to, you know, the one that's usually the hardest is the health information exchange. If that just doesn't make sense for you, if you're not doing transitions of care and you're not going to send that summary of care to a large majority of your patients, then you can knock it out of the park with the other ones that are simpler, like patient education, medication reconciliation, providing online access to your patients. So lots of ways to be successful in this category. Okay, let's move on to CPIA. I'm going to make sure I give Mike some time to talk too. So CPIA is the brand new category, right? These are the clinical practice improvement activities. It counts for 15%. It's going to be attestation. So how do I let CMS know I did this? Yes, you need to keep good documentation, but it's going to be attestation, very much like what we've done for MU all these years. There will be high and medium CPIAs. You need to do either 2 highs or 4 mediums or some combination thereof, and we can help you navigate this and help you make good choices. Some of the activities here will actually give you bonus points in the ACI category. So it sounds scary because we don't really know a whole lot about it, but CMS has done a nice job of publishing lists of CPIAs that they consider, the ones you ought to be going after. So we'll talk about those when we do our consulting with you guys. Okay, so let's move on to cost. Even though cost doesn't count this year, I will say ignore this at your peril. You really, let's get used to this concept, right? Let's use the transition year they've given us to get good at this so that it's not slamming us in the face when we have to do it in 2018 for a whole year and be good at it. This is a tricky topic because it's kind of mysterious. Like, there's no dashboard that's tracking this. This is all claims-based. You don't report anything. CMS is keeping track of this for you. The key takeaways here are there are 41 episodes that they are tracking. Episodes and clinical condition groups that they are looking at. You need to know what those are and where you fall into them. There's also the attribution models can be very confusing. So what is it? What happens that makes this patient count in my bucket? Know what those trigger events are. So use the transition year to become educated about the cost performance category. Okay, moving on. I think we're going to get to the good stuff. What's going on in the GlowStream product that's going to help me? So you can move to the next slide, Mike. And this slide should not be, oh, so I'm showing you the menu path to the new dashboards, right? These are in 80, 81, which kudos to us. I'm going to toot our horn for just a second, right? The rule wasn't finalized, I don't think, until November. You can get this in GlowStream today. So we worked really quickly to get this out in the product. You can, so if you're on 8081, you can get to your quality dashboard and your ACI dashboard. So let's move on and take a look at what those dashboards actually look like, because this is where I think you will be able to sigh a sigh of relief here. This should look very, very, very much like your CQM dashboard. We've added some intelligence here, right? You'll see that quality category column. I wanted it to be very obvious to you what's a high priority item, what's outcome, what's cross-cutting. They actually removed the cross-cutting concept for this year. We're leaving it in the product because I think it's coming back. For this year, you can ignore it, but going forward, I think we're going to have to pay attention to the cross-cutting measures like we did with PQRS. But this is going to help me make choices about which measures I should really be going after. You're going to be watching your numerators and denominators and that performance percentage. That's what's going to translate into your final score. So getting your score as high as possible will be important here. Understanding the workflow that's required to make those numerators and denominators bump will be important. You'll have to understand the minimum case threshold, right? If your denominator is less than 20, you won't be able to count that measure. So you're going to want to be tracking this and measuring your 6, and I recommend you target 7 or 8 just in case one of them, doesn't work out for you as you get farther into your reporting category. So let's go to the next slide, Mike, so I can wrap this up and let you speak. The ACI category, again, looks really, really, really like our MU dashboard. We've just added the bells and whistles that let you easily track what are the measures that are in the base score. I have to have one patient in each of those base scores, except for the security risk analysis, to get my base of 50. Then the remaining 50% come from the performance in those categories where you can see there's we're giving you the performance score and then the max possible. So some of them are double weighted because we are in the 2017 transition ACI dashboard because we're 2014 edition certified. Don't fret over that. This is just, it's a little simpler to meet ACI using this dashboard than folks who've been upgraded technology that's out there certified to the 2015 edition. We will do that in 2018. All right, let's move. I think, Mike, I'm going to be throwing it back over to you.
Thank you, Julie. I appreciate it. And thank you for all the work and energy and effort you've done to bring it all together and put it into a product and be able to push that out to the community. The other thing I'd like to just note with everybody is that Julie's obviously been intimate with this since the original rule, and then obviously through the final rule, and then developing the technology and then rolling it out, and then advising us internally and externally and back to Medicare and out to all of you. And so we've done our best job possible at simplifying this. However, we do recognize that it's very complicated, and not only that, but this is just an additional responsibility now on your plate that's something you hadn't had to do before. And so we've really tried to figure out, well, how do we help you? How do we help you be successful? How do we take the burden off of you? And that's where I go back to, we've simplified our offers. We really have 2 offers. They're both all-inclusive offers. We have the TRIARC Complete, which is RCM, and then we have TRIARC Pro, which excludes RCM. But I think what's the most important about these offers are that we're assigning a performance manager to every one of the people and organizations that sign up for one of these offers. And the purpose of performance management is to look at these programs and to help you figure out what the best way and what the best measures are, and what your decimals are, and deciles are, I should say, and to really help you think about how to move forward in this new world. And we obviously are focused heavily on the macro, the MIPS program, because it's here in front of us. but we also recognize that there are many other payers out there that have their own programs from PCMH and quality programs and all the reporting and other requirements that those entail. And so we've really tried to simplify it. We want to partner with you to make it easier for you and to ease your transition into value-based care. I think one of the most significant things that's come out of this is the transparency. Historically, there's not been much transparency in the marketplace, and so we really haven't had to worry about that. But increasingly, there's a lot of pressure on transparency across the healthcare ecosystem. Some states are different than others. Some states require it's a mandatory law that all information, obviously not patient information, but provider performance information is public information. And so, we just know that we're entering into an era where there's more competition and the benchmarks are quickly evolving, and we want to help you be successful. Obviously, we're not successful without your success, and so, these programs were designed to do that. They include, a bunch of things. I'm not going to go through all of these. We'll have this presentation available for download, and if someone wants a copy of it, you can take a copy of it. Or, of course, you can contact us at any time, and we'll walk you through the details here. I think one of the most important things that we want to come out of this webinar today is, one, to start you down the journey, get you educated. The timeline has started. We're already into the race, 2 weeks, and we recognize that a lot of people, are not even started yet, and so we want to urge you and others to get started and get educated, develop a plan, create a vision, get your practice together and develop a plan. We want to help you with that plan as much as possible. This is an example of a spreadsheet on how to choose quality measures, which ones, what the deciles are, et cetera, et cetera. We want to work with you to do that. You need to appoint a champion, and you need to get started now, and these programs are in place, and they're only going to get more complex as we move forward. And so we don't want any of those phone calls a year from now or 6 months from now in a panic state that says, we need your urgent help. We want to try to stay ahead of this, get ahead, stay ahead, and help you be successful. And we've got the programs and the tools and technologies and services to help you do that. So, it seems overwhelming, and for many people it truly is, and we respect that. But if you do get your arms wrapped around it, it is an opportunity to separate yourself from the competition, since everything is going to be publicly available. And if you really focus and put your energy around that, I think you can be super successful in this market and earn significant incentives, not only monetary incentives, but also practice incentives where you can brag about your practice and have the data to do so, and that can also impact how you deal with the commercial payers or the other payers throughout the ecosystem. It is really incredibly important. Tracking and benchmarking and really looking at these things can help you and will help you. I know it's daunting and it's scary at first when you don't have the information, but once you gather the information and get it and get on board, and get a program in place and get the support that you need, it will become more manageable. And then we understand there's folks out there who either believe that the MACRA is going to be overturned, or they don't believe in it philosophically for one reason or another, or they're at the end of their career. I mean, there's just lots of reasons for reticence out there, or the program will change, et cetera, et cetera. We've heard all those things. I will just assure you, in talking to all the payers, and we continually do that, is there's no turning back from the value-based story. Value-based is true north at this point, and everyone's thinking about how to create better alignment and how to create the programs that make sense and align your interest with the payers and the patient's interest. And so I think this is just this is here to stay. This is a new way of doing business, and we're here to partner with you to help you, leverage and stay independent, and we want to be your partner to do that. So we're here. We will continue to actively engage with you to help you achieve your goals and be supportive of your independence. There's a content here. Most of you know these folks. You have Brent or Patrick as your account managers, or you have myself or Sabrina or Julie or any of us are available for your support. So let us know. We will continuously be reaching out to you about these programs, trying to check in with you and see what the status is. And so please expect information from us and be responsive. You know, we do have important and relative information for you, relevant information for you. And so, you know, we look forward to engaging you and helping you succeed, and we look forward to continuing our partnership with you. Thank you all very much. I appreciate your attendance. I appreciate your focus on this issue, and let us know how we can support you in the future. Have a great day, everyone.